Thank you, everyone, and good evening. I would like to thank Professor Salvatore Di Somma for this big opportunity, and I would like also to thank Dr. Ruggeri for this introduction. I will talk about the rapid detection of hemolysis in emergency departments. The healthcare system is increasingly relying on clinical laboratory data that unfortunately are not free from errors. Hemolysis as a pre-analytical error is the most frequent of it, and in fact, it seems to be present in around 2 to 10% of blood gas specimens analyzed in a central lab. As we can see from this graphic, a study of 2009 of Lippi et al. Demonstrated that the majority of the hemolytic samples in a lab were coming from the emergency department. This is happening also because the POCT devices used in the emergency department are not considering the presence of hemolysis. And also, it could lead to a wrong decision based on reliable data. So we designed a study that has 3 main aims. The first one is to analyze the prevalence of hemolysis in blood gas samples using a POCT analyzer in ED. This study started in March of this year. We are still collecting samples and is also the topic of this speech. The second aim is a method comparison study that used this device that you can see in the picture below and the Abbott Architect that is our reference method in our lab. The third part is to perform a user evaluation study regarding the user-friendliness of the device with a survey. As you can see, MCheck has developed a point-of-care system for immediate hemolysis detection that is designed to search free hemoglobin in plasma and consists of an S-test, a V-test, and an H10 reader. We have a target sample of 700 samples obtained in emergency department by any patient undergoing an arterial or venous blood analysis for acute diseases in emergency department of San Giovanni hospitals in Rome. The exclusion criteria are, for example, insufficient amount of blood for the hemolysis test and visible clots in the syringe and so on. The operator has to perform the sampling and then has to perform the hemolysis test. After, he had to collect the data from the hemolysis test and also the data coming from the usual analysis. After, he has to tell to the health worker the results and has to collect the decision before and after the healthcare workers knows the response from the hemolysis test. These are our patients' characteristics. We collect until now 225 arterial samples, and 26 of them came back as hemolyzed, and 199 not hemolyzed. So we have an hemolysis frequency of 11.6%. The majority of our patients were men, in fact, they were 53% of them, and we divided also the patients for triad symptoms, and the vast majority obviously had dyspnea as presentation symptoms. We also have done a research for hemolysis in each group, but we couldn't find a statistically significant relationship between the underlying disease and the presence of hemolysis. These are our preliminary results, and as we can see, important values are influenced by it. In fact, we can see an important increase of potassium and an important decrease in PO2. And 3 values came back as statistically significant as potassium, pH, and PO2. So this could definitely lead to a wrong clinical decision if hemolysis it goes undetected. Also from this graphic, we can see how hemolysis is varying by individual operator, but obviously we know that as a pre-analytical error, hemolysis is strongly dependent on the skills of the operator. So obviously training is definitely important in a department as the emergency one that has a lot of workers in it. We collect the decision that were made from the by the healthcare workers after the knowing that the samples were hemolyzed, and as we can see, the 58% of them modified their decision. And so there is room for improvement if hemolysis is detected. In conclusion, hemolysis is frequent in blood gas samples, and is therefore important to identify hemolysis as soon as possible, especially in the emergency department, where time management is highly important and critically ill patients are more prevalent. Hemolysis impact important blood gas analysis results, such as potassium, pH, and PO2, and operator variance is also an important factor. So we have some intents. We want to continue the project collecting samples for this part of the study and the next two parts of the studies. We want to promote a new study to understand better how much hemolysis can be influenced in matter of time and clinical decision in ED. And we want to invest obviously more resources in training for the healthcare staff. And it is important to learn to detect hemolysis sooner and with more precision to improve the management of the critically ill patients. Thank you.
Excellent, Marianna. And any question? Please.
Thank you, excellent presentation. How could you distinguish between hemolysis because of the technique of taking samples from real hemolytic problem of a patient?
Yeah, we had this tool that is, I can show maybe with the slide the tool. The MCheck developed this system that was really easy to use. Actually, we tested the samples, and we have a system of two green lights, a green light that it's saying that the sample was not hemolyzed, and a red light that said that the sample was not hemolyzed. So it was pretty easy to understand if the sample was hemolyzed or not.
Okay, yes. Just.
So, Marianna, the question from Professor Masipi was a little bit different.
Yes.
Because this was asking, how can you distinguish on the reason of hemolysis if there is a pre-analytic error, right?
Yeah.
Or, let's say, intravascular hemolysis before, right? So the question is how much you can distinguish about the hemolysis that was done because of error of the operator, or seems be done because of the disease. It seems from the results you show that there is some relationship with the infection. So it seems that the infection is
not significant, actually.
but was not significant. So it seems that the majority is due to error in taking blood.
Graphic that shows the prevalence.
Sorry, but I was just addressing Dr. Masipi's question.
From hemolysis, we also checked each one of the operator that was participating to the study, and actually from a graphic that I've shown, you could see that there is a variance between operators. So that's why we can see that.
Okay.
Thank you very much for this. Thank you. Thank you very much for the presentation of this very interesting data. I was just wondering, you said that 58% of the operators changed their management strategy of the patient, depending on the fact if the sample was marked as hemolytic or not. But so the operator knew that the sample was hemolytic, but based on what did they change their management on the patient? Did they perform another blood sample analysis, or how did they do it?
No, actually we tricked them. So we gave before the results without telling them if the sample came back hemolyzed or not. After they have take some decisions, we have told them that the sample was hemolyzed or not, and so we collect also the decisions that they have made after.
But did you actually redo the sample and check if there was hemolysis again? Because
in some cases, yes. In some cases, yes. We have done again. We have resampled. So.
I think it's very important because I'm an emergency physician, and I know, many decisions are taken by hemogas analysis. No, so it's a very interesting study. Any question?
So, as my understanding, this machine cannot tell you why they're hemolyzed, and the most common one is operator error. So we just repeat it. The less common one is spurious. That's spurious. The less common one is pseudo-hyperkalemia that occurs in patients who have very high white cells, very high platelets, hereditary spherocytosis where they have very fragile cells. And there's a trick for that. All you have to do is use a blood glass syringe so there's no suction, so the cells don't break. And then you do a point of care analyzer, so there's no centrifuge, so the cells don't break.
Yeah.
And that you will have a normal potassium. When you first pull it, it'll get a potassium like of 7, and you'll think it's hemolyzed. So, but this should work if you prepare the sample correctly. So if you have an elevated, you think it's hemolyzed, and then you do the other technique with the blood gas and the point of care, you should get a normal reading on this machine.
Yeah, definitely is interesting.
Again, Marianna, the question that was coming from the floor was not completely well addressed. He was asking the methods, right? And I think it's something that we have to clarify. So the project was designed in double blind. So the operator was not supposed to be alerted by the presence of hemolysis because it was observational. This is the way that we are making the study. So officially, this is not allowed. But then, after that, they came up and said, this is hemolysis, you want to recheck. And then after recheck, he was thinking to recheck again and send to the central lab. So this is a little bit biased on the design, but the design was correctly, and we are making the same for next 700 patients to make double blind. That is the way that you really want. But now the next step is compare with the central lab, because in point of care blood gas analysis, you not get the chance. And I really enjoy what you say, Frank, to use appropriate in the future and see if it is really due to technology that you use to take syringe, because I think this will be also important in the future. But at the end of the day, it's something there that we should check.
Okay, thank you very much.
Thank you.